Okay, we have almost a majority of everybody that needs to be here, and we're going to go ahead and get started. A couple of updates. The videos are all loaded now onto YouTube for the first 2 days of classes. So if you had lab yesterday, if you had, and of course the lecture on Monday, those are all visible now. It took a while to get all of them loaded, but they're there and they work. So you probably also got an email from me last night saying welcome to the class and giving you my contact information. We were told to send that out yesterday. Don't ask me why, just do what we're told. And but if you need to get a hold of me, you know, you got my email address, and you go through eLearn, you got my phone number. And if you're on campus, I can meet with you. If you want to meet through Zoom, I can do that. That works very well. And I will, let's see, Kyle, did you get your, did you see your change in your class? Because I had you moved.
Yes, sir, I did.
Okay, good. Glad to see the system is working, so. Okay, so you should be okay with that. And so we're going to go ahead and get started. Anyway, well, before I go, does anyone have any questions about anything? Oh, and I will say that I added something new to the class. It's not mandatory. It's not required. I'm glad I'm not teaching English. There are a series of what we call soft chalks, video exercises that they have no credit attached to them, but they're good, useful learning tools. And there's one for each chapter. So there's one for introduction, one for chemistry, and so on. And a lot of people find them helpful. You try one and say, oh, this is incredibly boring. I don't need to do this. But, you know, I'd say give it a try. There's no credit attached to them, so there's no penalty if you don't do them. But they're there for your benefit. So, you know, if you want to give them a try, it's fine. I'm not going to be upset if you don't. They're just going to, again, reiterate what we've been talking about in the lecture, but it never hurts to hear something from a different perspective. So, okay. Now, I'm going to go ahead and open up the lecture. If I can find it here. Okay. And I think we were just starting to talk about negative feedback on Monday. So let me go ahead and get back into Zoom here and go into share screen. And of course it didn't. Oh, there it is. Okay, so you should see a screen that shows a negative feedback loop with for temperature. So I'm going to go ahead and open that up. So this is what we were talking about in class the other day about negative feedback loops and how our body uses them. See, negative feedback loops reverse the stimulus, and it's a very easy process for controlling. You simply turn the stimulus off. You know, if you leave a light on, you turn the light off. That's negative feedback. If the light's bothering you, you know, if the light's on and you can't sleep, you turn the light off so you can go to sleep. Something like that. Or you leave the car running, you turn the car off. things like that. Negative feedback reverses the initial stimulus. If you get hot, you sweat. If you get cold, you shiver. If you eat a donut, you release insulin to bring your blood sugar back down. That's negative feedback. And that is the classic way we control ourselves, control our body for nearly every activity we have. Every kind of stimulus is usually controlled through negative feedback. We have a set point. We have a set body temperature, for example, 37 degrees Celsius, 98.6 Fahrenheit. And most of us, our normal temperature fluctuates within maybe a tenth of a degree around that, because it's pretty unusual for us to be textbook perfect on our temperature and our blood pressure and our heart rate and things like that. So it's not a big deal if you're 98.2 or 98.5 or 98.7. Most that's fine. That's just a minor fluctuation. We fluctuate all the time, but our set point is whatever our temperature stays at or should stay at consistently. So if we vary significantly from that set point, we're going to take action to bring it back up or bring it back down. The same applies to blood pressure and blood pH, our acid levels in our blood, for example. It's blood sugar levels. We have a set point there, and we're going to bring it back down or bring it back up when we, for example, if you haven't eaten anything today and your blood sugar levels are dropping, the commercial, you're not yourself when you don't eat a Snickers bar. Well, there is a grain of truth into that, in that they're implying that because with a low blood sugar, you can't function properly. And that part's true. Snickers bar is probably not the best choice, but there are worse choices than Snickers bars. The point is that just like we can lower our blood sugar, we can raise our blood sugar if we need to get to our set point. And negative feedback loops are the ideal mechanism for doing that. So negative feedback loops work by turning off the original stimulus. If the stimulus is that your blood sugar is too low, we bring the blood sugar back up. If the blood sugar is too high, we bring it down. If your temperature is too low, we raise our body temperature. If our temperature is too high, we cool down. And so this is the classic control mechanism in our bodies, is this negative feedback loop. And I think we saw this picture here. A lot of textbooks love to have these type of diagrams. And what it does is it's attempting to show two loops at the same time. The top one is demonstrating what happens when you eat something that, with carbohydrates in it. So your blood, you eat an apple or you eat a donut, I don't care. Maybe you eat an apple and a donut. Maybe you eat an apple donut, so apple filled. Anyway, the point is that when you eat something, a lot of times your blood sugar goes up. And so your pancreas will respond to that. We have receptors that detect the rise in blood sugar. So your pancreas will produce and release insulin that allows our cells to take up more sugar. Any excess sugar goes into the liver and gets stored there as a starch-like substance called glycogen. Now, then that's all well and good. And it brings our blood glucose levels back down to, our blood sugar levels back to where they should be. If you didn't eat anything, had nothing to eat today, you were in such a hurry to open up your computer and get into class that you forgot to eat. Okay, well, maybe it's possible. Your liver, you will detect that, your body will detect that, and your pancreas won't release insulin, but it will release another hormone called glucagon. You can see it at the bottom of the screen here, glucagon. Glucagon goes to the liver, and all that, and that glycogen that you stored in the liver from eating the donut yesterday some of that glycogen will get released as glucose into your blood to bring your sugar, to bring your blood sugar back up to where it belongs. So these negative feedback loops work in both directions. We can raise blood sugar, we can lower blood sugar. The point is, any negative feedback loop works by reversing the stimulus. If the stimulus is that blood sugar is too low, we're going to raise it. If blood sugar is too high, we're going to lower it. We reverse the stimulus. Now, there is also a positive feedback loop in our bodies. We don't use those in a lot of places. A positive feedback loop in only a few cases is a good thing, because a positive loop will intensify the stimulus. You know, for example, if the stimulus was that you were getting hotter, getting warmer, a positive feedback loop would cause you to get even warmer, more warmer, getting hotter than you were before. We don't like that. Most positive feedback loops are not a good thing. However, there are a few places where positive feedback loops work very well for us. In childbirth, when a female has her uterine contractions, the contractions will increase. Every contraction leads to a greater contraction until the baby is delivered. So one contraction leads to a stronger contraction, which leads to an even stronger contraction, and that continues. That's a positive feedback loop. Blood clotting. When you cut yourself or when you're injured and you're bleeding, the initial clot that forms is small, but it gets bigger and bigger and bigger until it completely blocks all the bleeding coming out of the site of the injury. And so we have, again, a positive loop there. In most cases, there's only a few places where we use positive feedback loops in our bodies because since they exaggerate the stimulus, they tend to make it worse. For example, if you got cold and wet, you would shiver to warm up. Okay, that's what we do. We shiver to warm up. However, if you shiver enough, you're going to sweat. And when you sweat, the sweat evaporates and makes you cold. So now you have to shiver some more to warm up again. And now you're going to sweat some more. So you're cold and wet, and you exaggerate the stimulus. You make it worse each time by warming up and sweating more, and then shivering again to warm up even more. And so what happens is the person that becomes cold and wet and can't warm up ends up developing hypothermia, and people can die from hypothermia. People think hypothermia kills people. It's got to be like -30 with ice and snow and polar bears running around behind you. Most people that die from hypothermia die when the air temperature is in the 50s, simply because they fell into a situation where they could not get warmed up. Every time they warmed up by shivering, they perspired and they made themselves cold again. So we really don't like to see positive feedback loops. There's only a couple of them in our bodies that work very well. So, and here are the examples. Of course, childbirth is a positive loop. The more when the baby's head presses against the cervix of the female, that stimulates the release of a hormone, which causes uterine contractions. And the more the baby presses, the more that hormone is going to get released. And every time you have a contraction, it causes the release of even more hormone, so it amplifies itself. Blood clotting is a similar principle, in that when you release some platelets, they call in all their friends and neighbors. Platelets are what we use to start our clotting process. There's the little purple things right there. As we call in all of our friends and neighbors as the platelets, once they get to the site of the injury, they start calling in all of their friends and neighbors until you get this massive congregation of platelets, and it keeps happening until we get the injury plugged. Now, the problem we have is, well, actually, it's not a problem. We like to maintain homeostasis, the balance. Homeostasis is, the status quo. Everything's normal. We are all within. We're keeping all of our categories like blood pressure and temperature and blood sugar and body weight and heart rate and breathing rate, all within normal ranges. We're not out of range on anything. And that's again what we call homeostasis. As we age, it becomes harder and harder to keep everything in balance. Organ systems get older. We all the organ systems get older. Some wear out faster than others. Sometimes the kidneys wear out sooner. Many people have issues with their heart. Many people have issues with blood pressure. Many people have issues with blood sugar levels. We have almost an epidemic of type 2 diabetes in the United States. So it becomes harder and harder to maintain homeostasis as we get older, which raises the possibility of moving into a disease state. Once we start developing heart issues, if they're not treated properly or if they're ignored, they're going to get worse. Heart failure is one of those conditions. Heart failure is such a term, that it doesn't really mean anything the way it says. Congestive heart failure means it is a specific type of disease where the heart is getting overwhelmed by the lack of blood it's pumping. And we'll talk a lot about that in AP2. The point is that's once the heart enters into a diseased state like that, where the heart enlarges, you probably heard about people that have enlarged hearts and stuff like that. The heart doesn't revert back to its normal healthy state. And unlike a lot of things in dealing with the heart, bigger isn't better. When the heart enlarges, it actually gets weaker. So we don't like to see that because we can't reverse that. We can't fix that. When a heart becomes weaker, it becomes flabby. And so when we start down that pathway, when different organ systems start to wear out, it's harder and harder to maintain homeostasis in here. It's harder to fix the problem that we run into. And we see that on a lot of things. I just saw a study yesterday, in fact, that said there has been a 98% increase. Imagine a 98% increase in type 2 diabetes in young adults, 18 to 30 years old. A 98%, that's almost 100, that's a lot, over the past 20 years. And how come? Well, there's all sorts of ways we can speculate on that. But type 2 diabetes, there's two types of diabetes. There is juvenile diabetes, which is type 1, which is caused by, usually affects children, starts out in children. It's a lifetime condition, and it's caused by failure to produce insulin. Type 2 diabetes is what we used to call adult onset, because it usually didn't occur until you were over 40 if your patient was overweight and overfed and underexercised. Say it like that. Doesn't mean everybody that's over 40, overweight, and underexercised is going to get type 2 diabetes, but those are the prime conditions. Don't expect to see it in someone who's 20 years old, and yet there's almost 100% increase in the occurrence of that type of diabetes. that's a little young to be out of balance, for your blood sugar levels. Okay. Now, one of the things that we can do, there was a point to that slide from the other day of the 87 nails in the digestive system. That's a non-invasive technique to look at a person and say, hey, why you're not in homeostasis anymore. You've got 87 nails in your digestive system. Probably, if you said that to them, they'd probably prefer the 87 nails. The point is that X-rays are a great non-invasive technique. We're all about non-invasive approaches to the body, because every time you invade the body, surgery or any kind of surgical procedure, there's always a risk. The risk factor is usually pretty low, but there's always a risk in here because your patient could conceivably die during the procedure. Risk is usually very low. There's a risk when you get your teeth cleaned. There's a risk from having dental work done at all. There's a risk for routine operations. There's always a risk. Non-invasive techniques can reduce that risk tremendously, like X-rays. This is a PET scan. This is what's known as a positive emission tomography. This is very good in identifying cancer growth. Cancer cells seem to have a propensity to suck up lots of glucose. And the PET scan can detect where tissues are that are using a lot, I guess it's a technical term, high, as they say, relatively high glucose, high sugar use in the body. And so you can spot cancers, tumors growing in the chest, in the colon, in different locations, in the lungs, different locations throughout the body. We're going to see PET scans. We look at breast cancers and cervical cancers and prostate cancers, a lot of different types of cancers, lung cancers going to show up on PET scans. It's a non-invasive way. You don't have to expose a patient to a surgical procedure to see what's inside. Okay. So we're going to do all this kind of work to your patient. We ought to know some of the terms. Now, there is a classic definition here for your patient, and that's called the anatomical position. The anatomical position is a standard position that where you have your patient standing upright or laying flat on their back. It works either way. Standing upright, feet apart, and the palms are facing outward, facing forward, with the thumbs pointing away from the sides of the body, like the picture here. This is the anatomical position. That is the standard position. If you say anatomical position to anybody in healthcare, they're going to know what that is. So that it's a frame of reference that everybody uses. Now, I will tell you that people have been known, faculty have been known to put questions on the final exam about the anatomical position. And they'll have I don't know why, but one of my favorite distractors, the wrong answer for that is the anatomical position is, and then you have choices. And my favorite wrong answer choice is the most comfortable position to take when dissecting a cadaver. So sounds reasonable, but no, it's just, patients standing upright or flat on their back, palms facing outward, thumbs out at the side. This is the anatomical position. And we can use that anatomical position to base the direction of our terms. All of our directional terms are based on the anatomical position. So we don't have to worry about, is it your left or my left? Is it your right or my right? We use the standard position of we use the standard anatomical position. So let's get this together. Okay. So here are some of the terms. Now we're not going to, there's going to be a lot of terms. We're not going to learn them all right now. You will actually learn most of these terms as we go through this semester. So don't start, don't be concerned about the all the terminology. As we go through it, the more we use them, the more comfortable you'll be with them, the better you'll be able to remember them. So anterior and posterior. Anterior means front. Posterior means back. That should be, everybody can think of what a posterior is. Anterior also means ventral. Ventral is the belly side, the bottom side of an individual. If you think of your dog or your cat, the ventral surface is the side their belly's on. The posterior surface is also the dorsal surface. Think of the dorsal fin on a shark. Imagine if this individual here was it really a shark and had a fin coming out their back. It's a dorsal fin. If you've ever seen sharks at the beach or porpoises or anything else, or any kind of large fish with a fin that sticks up, that's a dorsal fin. That's on the back. Superior and inferior. Superior means above. Inferior means below. Superior and inferior, above and below. The problem with those is that there's an awful lot of flexibility in that. So I try to stay away from that. Lateral and medial. Now this is something we will use all the time. In the anatomical position, we have a midline, an imaginary midline runs right down the middle of the body. Anything that's close to the midline is medial. The closer you are to the midline is a medial position. The further away from the midline you are is lateral. So an easy way to remember that is take a look at your foot. You look at your foot, look at your big toe. Your big toe is on the inside portion of your foot. Most feet have a big toe on the inside of their foot. So your big toe is on the medial side of your foot because it's closer to the imaginary midline that runs down the middle of your body. So your big toe is on the medial side of your foot. Your little toe is on the lateral side because it's on the outside. And that never changes because we don't flip our foot over like we can flip our hand back and forth, So, so when you're looking at a skeleton, when you're looking at a leg model with muscles on it, and you want to remember which side is medial and which side is lateral, just look for the big toe. The big toe is always on the medial side, whether it's a left leg or a right leg. That means the little toe is on the outside, which is always lateral. If you know that, then you know the position of every muscle and bone inside the leg. So medial is close to the midline, lateral is away. That's a term we will use a lot. Proximal and distal, again, that's one of those sort of squishy terms that fluctuate depending on the location. Proximal means, for example, is the elbow proximal to the shoulder? Is it close to the shoulder? Well, it's closer to the shoulder than the wrist is. You would say that the wrist is distal. Distal means further away. Proximal means closer. And it's one of those somewhat confusing terms. So the ones that we will use the most are going to be medial and lateral, anterior and posterior. Those are the ones that we're going to use the most. Anterior and posterior, dorsal ventral, and medial and lateral. Those are the terms, the terminology that we will use most frequently. We're not even going to use superior and inferior very often. So as long as you can identify the medial and lateral structures, you'll be just fine. So this is a couple questions here. Just consider this and don't worry about it. True and false. The mouth is superior to the nose. Superior means above. Mouth, in most cases, is below the nose. So that's a false statement. The stomach is inferior to the mammary area. Well, the stomach is in the abdominal cavity. The mammary area is in the thoracic cavity. That's your chest. So that's a true statement. The nose is medial to the left eye. Well, that would, again, now we're sort of into squishy stuff, but yeah, because the nose is in the right on the midline. The hand is proximal to the elbow. Yes, it's near the elbow. The knee is distal to the ankle. Depends. And the vertebral area is lateral to the axillary area. The axillary area is your armpit, your vertebrae, your backbone. So is the vertebrae towards the midline of your body, or is it away from the armpit, beyond the armpit? Well, last time I checked, all our backbone's right in along the midline. So that's what, if these questions got you confused, welcome to the club, because a lot of it depends on perspective. So that's why I like to leave it at anterior, posterior, ventral, dorsal, and medial, lateral. You will use medial and lateral a lot. So we take a look at our bodies. We have two big divisions in here. We have the axial division and the appendicular division. Axial is meaning right along the vertical axis, straight up and down. So we have the head with the skull. We have the neck with the vertebrae, which are also found in the trunk, which is also called the torso. So that gives us our ribs. So we have our backbone, our ribs, our sternum, and our skull. That's everything in a straight line, straight up and down. That's the axial division. The appendicular division is everything else. It is the appendages, the arms and legs, fingers and toes, hands and feet. Okay. So our kneecaps and our shoulder blades, and, everything, our clavicles, our collarbones. And so all this other stuff, all the leg, all the girdles, the pelvic girdle, that's what we call the hip bones, and the where the femurs come together, that's the pelvic girdle. We have a pectoral girdle or a shoulder girdle, where the clavicle, the collarbone, and the scapula of the shoulder blade come together with the humerus, the large bone of the upper arm. That's what those are the girdles. And so we have, and we'll spend a lot of time in lab talking about these various bones. So those are the two big divisions in our bodies. Now, within those divisions, we have certain terminology that gives us regions. These are the regional terms of the human body. And no, this is not going to be on the lecture test. It's not even going to be on the first lab test, because we're going to pick all this information up as we go along. We For example, the axilla, I mentioned that. The axillary region is the area under the armpit. We'll talk about the axillary lymph nodes a lot in AP2 because that's, a prime location for breast cancer cells to metastasize, to move to. So we'll talk about that. We'll talk about the carpal bones, the bones of the wrist. You can see that down here. The digits are the phalanges. The patella is your kneecap. See, a lot of these you've already heard. Again, the tarsal bones are the bones of the ankle. By the way, there is no ankle bone. We have the femur, the largest bone in the body, the inguinal region, the umbilicus, where our belly button is located, our hip bones, the abdomen, the mammary area, the thorax, the chest cavity, the cervical region of the neck, the nasal area. Many of these we've already heard. So it's not going to be that hard to put it together. I will say that there is, if I remember correctly, there is a question on the final exam about Polex. I don't know why. I didn't put it there because the final exam is a group effort by the A&P faculty, and we throw all of our favorite questions into a pile, and they get put into a test bank, and then the test bank spits out 100 questions every semester. But somebody insists on putting in Polex, is the Polex the thumb or the great toe? Because the big toe is called the halux. And we have the Polex and the halux. Just make sure you know the difference of them. I don't know why that's important. That's not a hard-hitting A&P question, but it does show up on the final exam most times. So so just make sure that's about the only one I want to see. You've got to remember that one. Anyway, moving on. On the posterior surface of the human, we have the olecranon. That's the proper terminology for the elbow. We have the sacrum. The sacrum is the large bone at the base of the spinal column. It's where we have the sacroiliac joint. The gluteus, the butt. Who doesn't know what the gluteus maximus is? Well, there's a gluteus minimus and the gluteus medius. Because one thing about A&P, about a human anatomy, if you have a maximus term, you're going to have a minimus term. Or if you have a major, you're going to have a minor. We have the pectoralis major, you're going to have a pectoralis minor. So just, if you have a structure named lateral something, you're going to usually have a medial something. So there's some real consistency in naming. Here's one, popliteal. There's a large vein that runs behind our knee that can cause trouble with blood clots for people that travel long distances and don't move their legs. We'll talk about that in AP2 when we start looking at blood vessels. Calcaneus is the heel of your foot. The sole of your foot is called the plantar. So there's a lot of these terms that, again, we've already seen them. So while it looks like there's an awful lot of terms here, many of them we are already familiar with. And what we will see is that by the time we get done with this, with AP1, you're going to know most of them simply by hearing them again and again. I'm not going to say, okay, sit down and go through all these and learn them. Okay, another way we can divide the body up is imagine that we can divide it not only into divisions and regions, but by planes. A vertical plane, a horizontal plane, a transverse plane, if you will, a side. Now, So we have this individual here that is being separated into three different planes. The left and right side, if we divide the body into left and right, we call it a sagittal plane. A sagittal plane, left and right side. If we run right down the midline, we call it a mid-sagittal plane. If we divide the body between front and back, as we say, anterior or posterior, or dorsal ventral, we call that a frontal or coronal plane. There is a suture, joint in the skull called the coronal suture. It's a zigzag line that runs across the top of the skull. Imagine a plane that separates the individual into front and back, anterior and posterior, right at that point. And then the transverse plane is what we call the cross section. That gives you superior and inferior, top and bottom, if you will. And these planes can be used to separate any portion of the body that you want. A sagittal plane doesn't have to go through the middle like it does here. It can go through the elbow, so that you're going right through the middle of the elbow with 95% of the body on one side and the last 5% on the other, because it's an imaginary plane. It's not like you're actually going to physically cut them in half or something like that. So, okay, so the planes: sagittal plane, frontal, coronal plane, transverse or horizontal plane. A cut through any portion of the body, or a cut or a section, is named after these various planes. So a sagittal cut would divide the body into left and right sides. It doesn't matter where the cut would be, the section would be. Mid-sagittal runs right down the middle. Parasagittal is anywhere on either side. So a sagittal cut gives you a left and right segment. It doesn't matter how big or how small the segments are. So we have the mid-sagittal right down the middle on the midline, parasagittal off center. And that off center can be anywhere on either side of the body. Frontal planes give you front and back. Again, it can be anywhere front and back. It can be, you could have a frontal cut that runs right through the tip of the nose and only includes the tip of the nose on one side and has everything else behind it. Or it can be running through right in front of the butt, right through the gluteus maximus muscle. So you have everything in front of that and just a section behind it. It doesn't matter. Frontal cuts are going to give you anterior and posterior, front and back. Transverse gives you a cross section. It can be from the bottom of your feet or the top of your head or anywhere in between. It's going to give you a transverse cut. And an oblique section gives you an angled cut. So here we see an individual with a mid-sagittal plane being demonstrated. And this is an MRI, magnetic resonance imagery. They put you in a big tube and it clicks and clanks. And of course, if it's open, it's not nearly as bad. And it gives you a view of the interior of the body. Again, this is an ideal non-invasive technique. And what you're seeing here, this cut right down the middle of the individual shows you the vertebrae. It shows you the rectum. It shows you the intestines here. You can, if you go far enough up, you would see the ribs and the sternum, and you would see the various organs in the abdominal cavity. So an ideal tool for examining the internal structures of an individual, without having to open them up. So This is what you made the cut you made the cut right down the middle of the body, and in this case, you're looking at. It appears that you're looking at the left side of the body because the sagittal cut gives you left and right sides. How would we use it? Well, here's a great example right here. Here is an individual that accidentally shot themselves in the heart with a roofing nail. And one of those, hey, this thing isn't working. Is it loaded? And for some reason, they decided to turn the gun around while they were looking at it. And as usually happens in cases like that, it went off. Place the nail right into the patient's heart. This is a mid-sagittal cut. You can see the vertebrae here. This is great in the vertebrae. You can see portions of the ribs. You can see the organs, and here's the heart. And it's one of those things that penetrating injury to the heart like this is not nearly as devastating as you think, because the heart's pretty remarkable. Depending on where in the heart it went, it nearly always closes up around the penetrating. If it doesn't go through, it nearly always the heart will close up around the penetrating injury. You have some trauma to the heart, and you have some bleeding. Yes, this is serious, but it's not like you see in the movies where someone is shot or stabbed and they're instantly dead. This individual recovered very nicely from this because the heart muscle closed around the injury. As long as no one tried to pull the nail out of the heart, the individual would be in good shape. That's why you have a patient that presents with a penetrating injury to the heart, a knife, any kind of sharp object, don't pull it out. Stabilize it. Usually when the paramedics bring them in, they're going to be usually stabilized with the object that's still there. So anyway, MRIs can show you this. MRIs can show you what's going on here without having to, let's open them up and see what we got type of situation. Now this is a frontal cut, frontal or coronal cut. Dividing us into front and back, anterior, posterior. Now we can see the lungs. We can see the right and left lungs. We can see the heart. We can see the liver, the stomach, the spleen. All of these structures in here our perspective is we are looking straight on at her. Everything's where it belongs. This is her right lung because we're looking at her straight on it. So it's a revert. The labeling is correct. Our perspective says, oh no, that's got to be that's on the left side. No, it's really the right lung. So anyway, but we see the heart and lungs. We see the stomach, the spleen, the liver, gallbladder right underneath there. We see the large organs in place. We see the heads of the humerus there and there at the shoulder. We can see the elbow there and there. And depending on where the cut is, do we see the whole bone or do we only see a portion of the bone? In this case, we only see the heads of the humerus on each side because this cut is going through the head, but not through the rest of the bone because the rest of the bone isn't immediately lined up along the middle. So anyway, the point is though, didn't have to do a thing except to have her lay down in the or stand in the MRI and have the image taken. Here is a transverse cut. Transverse cut, very useful also for identifying the location of tumors, damaged blood vessels, penetrating injuries, blunt force trauma. Here we see the liver, the spleen, the aorta, right here, largest blood vessel in the body. There's the spinal cord inside the spinal column. Let's see, pancreas and spleen. So we are just below, the cut is just below the stomach in here. So we can see, the internal organs of our individual. We can see is everything okay? We're too low to see the lungs. And remember now, the MRI is going to be a snapshot at each location. So if you want to view the whole body, you have to go segment by segment by segment by segment all the way down. But this, again, is a great approach here. This is an MRI of a segment in the brain. This is a transverse cut of the head at the level of the eyeballs. I mean, if you look here, you can see there are the lenses for the eyeballs right there. So we're right about the level of the lens in the eyeball, right about the top of the, right where the eyeball, should be the top of the nose, located here. We can see a portion of we can see this location of the brain. And so we can see everything that's going on in here. Is something taking place that shouldn't be taking place? Or is this just an interesting picture? Don't know. I don't see anything off the top of my head. I don't see anything unusual in the brain, except maybe these spots down here. So, but I'm not certain. Everything else seems like it. I don't see any bruising or anything like that. So, but then again, I'm not a radiologist. But this is a slice right through the level of the eyeballs. This one, I wish it didn't go so fast, but this is a whole body MRI of a transverse cut, starting from the top of the head, going all the way down to the feet. And if you watch this a couple times, you can see how we go through the head, the eyes, the nose, the torso. You can see all the internal organs in the abdominal region and the thoracic region. We go down the legs, we get to our feet. Notice also what the cross section of the arms and legs look like. They look like meat, and that's what they are. Skeletal muscle in this transverse cut looks an awful lot like bone-in round steak. You would get down in Food City, because it's the same pigment in there. The respiratory pigment that makes meat red is myoglobin. That's the same pigment that's in our skeletal muscles that are in animal skeletal muscles. And so a transverse cut here looks very similar to what you would see laying in the meat counter at Food City. And it's the pigment, the myoglobin, that makes the meat red. So, and when you get a piece of meat, if you eat beef and you order it rare and or medium rare, and it comes and there's this red fluid juices laying around there, that's not blood. That's the myoglobin coming out. Blood has been drained from that meat a long time ago, because if there was still blood present in the meat, it would be very unpleasant. So what you're seeing is the myoglobin draining out. There's very little, if any, blood present in that, because that meat hung in coolers for a long time for the blood to drain. Anyway, I digress. So that's us. That's a whole body cut from top to bottom, from the top of the head all the way to the toes, showing you what an MRI can do. So you can look at any segment of the body to identify issues. And having said, looking at all the different planes, we also have a series of cavities in our bodies. We have a lot of holes. We have a lot of holes in our head too, believe it or not. We have the dorsal body cavity and the ventral body cavity. The dorsal body cavity on the back side of the body, on the posterior side of the body, on the butt side of the body, if you will, has our cranial cavity for our brain, our spinal cavity for our spinal cord. That is our dorsal body cavity. Our ventral cavity is everything else. And that has a thoracic cavity with our heart and lungs and blood vessels and trachea and esophagus and our ribs. And then we have the diaphragm separates the thoracic cavity from the abdominal pelvic cavity. That's all. The ventral cavity is everything in front. The dorsal cavity is everything in the back. And this is a prettier picture, that's all. Cranial cavity and vertebral cavity make up the dorsal body cavity. It's all brain and spinal cord. Everything else is ventral. The chest cavity, the abdominal cavity, the pelvic cavity, you can say the thoracic cavity and the abdominopelvic cavity, doesn't matter. Those are the two big sections of the ventral, the belly side body cavity. Within the thoracic cavity, we have smaller structures for the lungs and for the heart. And the middle of the thoracic cavity is called the mediastinum. So. And of course, the dorsal body cavity is the most protected region of the human body. We have the skull, which protects the brain. And while the skull is not very heavy, it is very strong and gives our brain support and protection. The same applies to the spinal column. We have our spinal cord running through there. And the spinal column is the second most protective area of the body, right behind the skull. So we have the brain and the spinal cord, because that's us. That's the location of the central nervous system that makes us us. So everything else, everything feeds into the brain and spinal cord. So the ventral body cavity, as I said, we have what's known as the viscera, the internal organs, the lungs, the heart, the liver, the spleen, the gallbladder, the stomach, the pancreas, all this stuff, with large and small intestines. These are the viscera. These are the individual organs held in place thanks to the connective tissue, reticular fibers and stuff. We mentioned that in the lab yesterday and again today and tomorrow. We divide the ventral body cavity at the diaphragm, that sheet of muscle that's right below our rib cage. If you know where your sternum is, the breastbone, if you get down to the end of that, there's a point down at the end called the xiphoid process, and your diaphragm starts right below the xiphoid process. And you can see your diaphragm is right in here. You can't see it on here, but it's right there. So we have lungs above, lungs and heart, airway, and blood, large vessels here. And then we have all the abdominal viscera down here. So within the chest cavity, the thoracic cavity, we have the pleural cavities. Each lung is in a pleural cavity. The mediastinum, the middle of the thoracic cavity, contains the pericardial cavity. It's where the heart's located. The heart is surrounded by a membrane called the pericardium. We keep the heart protected inside there from friction. The lungs sit inside their pleural cavities, and they're heavily lubricated because we don't want any friction. And the heart sits inside the pericardial cavity, wrapped in its membrane called the pericardium, surrounded by a fluid. So it doesn't have any friction either, because our bodies don't like friction. we hate friction. You think that we don't have a lot of friction, just rub your hands together for a couple seconds and feel how warm they get. Just in 2 or 3 seconds of rubbing, that's friction. And our heart doesn't want it inside, while it's beating. Our lungs don't want friction while we're breathing. We don't want friction while we pass food through our bodies either. The abdominopelvic cavity is broken out into the abdominal cavity and the pelvic cavity. The abdominal cavity is the stomach, the liver, the intestines, the spleen, the gallbladder, pancreas, everything in that region. And then below that, you have the pelvic cavity, which has the urinary bladder, the reproductive organs, and the rectum. So, now how do we identify these regions? Well, there's 2 ways of doing it. We can divide the body up into the abdominal region into 4 quadrants or into 9 segments. And the 4 quadrants is very easy. I mean, your patient presents with pain lower, they've got pain in their lower abdomen on the right-hand side. It's tender. They've got a fever. The pain is very sharp. The first thing that crosses your mind is possibly the appendix, because it hurts a lot. So you would indicate that the patient has a sharp pain in their lower right quadrant. That's very good. Or they have a pain in the upper right quadrant. Well, up here in the upper right quadrant, you got your gallbladder. And so, if the gallbladder is inflamed, they're having a gallbladder attack. They've got nausea and vomiting and flatulence and high fever and a lot of pain. Might be the gallbladder. You don't want to rush into it, but it might be the gallbladder. But what happens if they have a pain that's all the way up here? Now, your right upper quadrant gives you the top of the large intestine and half the stomach and most of the liver. But suppose they have a pain way up in here. Maybe they have a cracked rib, or they have a pain, in the right lower quadrant, but it's not down where the appendix is, it's off to the side. Maybe it's a kidney stone. So in cases like that, where we want to be more precise, instead of saying right and left, upper and lower quadrants, which is very straightforward and very easy. And in most cases, that's all you're going to need. But in some cases, you want to be a little more precise, because a person with appendicitis, a person who has pain in their lower right quadrant, often doesn't have appendicitis. Maybe they do. But a lot of times, kidney stone pain can be found in the same location. It can be appendicitis, it can be a kidney stone, it can be gas causing the distension of the abdomen and the of the large intestine, and it can be very painful. So there's any number of things that can go along here, but there are, there really aren't that many terms you have to learn. The umbilical region is the easiest place to start. Everybody has a belly button. If you don't have a belly button, come and see me. We need to talk. Everybody has a belly button. That's the umbilicus, umbilical region here. The lumbar, we've all heard of the term lumbar, for lower back. So we have a lumbar region on either side of the umbilicus, right and left. We have a right and left iliac region. We have a right and left hypochondriac, and we have an epigastric and a hypogastric. So there really only are a few terms to learn here to be able to identify all 9 regions. The thing is that you want to try and be as precise as possible, because our bodies don't play fair. Where we sense pain, for example, isn't always where the problem is. For example, our gallbladder is right here. That little green thing that you see right there is supposed to be the gallbladder. But in most cases, or at least in a lot of cases, if the gallbladder is inflamed, you don't feel the pain there. A lot of people feel their pain over their right shoulder. So go figure that one out. It's something we call referred pain. And so our bodies send the pain signals down different pathways. We don't always have the pain where it's supposed to be. You know, kidney stone pain can be anywhere across the side and either flank. So can the appendix. I had a friend in college who had appendicitis, and he spent 2 days with severe pain in his left-hand side. And the infirmary at college insisted it couldn't be appendicitis because the pain was on the wrong side. And on the third day, it moved over to where it belonged. And he ended up going to the hospital. So, because pain can fool you. You know, so you can't just assume, pain in the lower right side, fever, nausea, vomiting, appendicitis. Well, pain's there, but it may be caused by something else. Okay, so just bear in mind that you know, upper right, lower right, upper left, lower left is a great tool. A lot of times, you know, when you're examining your patient, more than likely that when you're charting your patient, they're going to have these illustrations on there already. But you need to understand what can happen, what can, you know, why we have this phenomena of referred pain. And you're going to hear about this again in lecture and in lab. Okay, so surrounding these body cavities, we have membranes called serous membranes or serosa. These are, they produce a fluid called serous fluid, which if it was exposed to the outside would be called mucus. But because it's internal, we call it serous fluid. The membrane is made up of endothelial cells. You know, epithelial cells, for those of you that had lab yesterday, know that epithelial cells are the cells that cover the outside of our bodies and cover every opening in our bodies, and everything open to the outside. Serous membranes cover the surfaces that are internal. Same type of cell. They look just like simple squamous cells, for example. They have they have fluid generating cells very similar to goblet cells. They don't generate mucus, they generate serous fluid, and the serous fluid functions as a lubricant, so there is no friction. So we have, when we have a serous membrane, it shows up in 2 layers, and the fluid goes in between, sort of like a jelly sandwich, if you will, because jelly would be the, you know, imagine a great jelly sandwich, 2 slices of bread, and you have the fluid in between, the jelly in between. Well, that's how a serous membrane works. It has an outer layer, an inner layer, and it has fluid in the middle. Well, the outer layer is called the parietal membrane or parietal serosa, and that butts up against the body wall. So it's stuck, you know, like for the lungs, there is you have the pleural membrane, because it's the pleural cavity. We have the pleural membrane. We have the parietal pleura, which is the serous membrane that butts up against the chest wall, and you have the visceral pleura, which sticks to the surface of the lungs. The visceral surface always sticks to the viscera, wherever we are, whether we're lungs or gallbladder or intestines. The visceral membrane sticks to the viscera. The parietal membrane sticks to the wall, the outer wall. And the serous fluid is in between to function as a lubricant. And so here we see what it looks like, more or less. There's the pericardium. And you're going to hear all about this when we get into the heart in AP2. And if it sounds like I keep talking about AP2 because AP2 is better, it is. You're going to enjoy AP2 a whole lot more. But here we see our heart. The heart has the membrane that's called the pericardium. It has a parietal pericardium, which sticks to the chest wall, a visceral pericardium, which sticks to the heart surface, and a layer of fluid in between. The same for the lungs. We have the visceral pleura sticking to the surface of the lung, the parietal pleura sticking to the inside of the chest wall, and fluid in between, serous fluid in between. And this is what we see throughout the body, in the heart, the lungs, and in the abdominal cavity. And this is supposed to demonstrate how the pericardium surrounds the heart. If you were to take a balloon that you could press into the middle of the balloon and create a double layer. Frankly, I've tried this and it looks great in a picture, it doesn't work, but the idea is you're creating a double wall. And so this space in between here represents the area where the serous fluid would be located, with this inner layer being the visceral pericardium and the outer layer being the parietal pericardium. So the only reason that it doesn't work is every time I try and do it, the balloon goes flying out. So, okay, and that is the end of chapter 1. So we've just finished chapter 1. Does anybody have any questions on any of this?
Do you give study guides for the tests, for the lecture test?
Yes, I do. The study guides are located in the table of contents for eLearn. In eLearn, the study guides are down at the bottom of the table of contents listed as study guides. So for each test, there's a study guide, and there's also one for the final exam too. So
okay, thank you.
Certainly, definitely there. So, and let's see. Okay, so we're gonna. I'm gonna wrap it up here then. So on Monday, we'll start on chapter 2 on chemistry, and go from there. Lab this afternoon will be on the microscope, the human tissues, and on the skin. And yesterday, I probably went to about 220, I think, and covered all that. We were on a roll, so I didn't stop, but it makes it easier for next week. So anyway, it won't be that bad. So anyway, then I will get us out of here. I got us out 9 minutes early today. So, and I'll see some of you in lab, I guess. So, okay, otherwise we'll pick up on Monday morning at 9:30, looking at chapter 2 on chemistry. Thanks a lot, and I'll see you all later.